Let's welcome Fred Thomas to talk about Project ECHO in Colorado.
Good morning, everyone. I feel a little unfortunate that I get to speak after the speaker I had. You know, he's giving you sort of a play-action movie, and here I come, and I'm going to tell you about maybe The Crown or something, you know. So have some tea and listen with me. So I'm from Texas. I grew up in Texas and grew up near Lubbock, and then went to University of Texas, Tahoka, if you may know Tahoka. Yeah. Went to University of Texas, worked in Austin for about 20 years, and then moved to Galveston, Texas for 10 years, and ran telemedicine down there for a few years. And really at the time when I was transferring to Colorado, we were looking for, I was maybe let's say the sole liberal in male liberal, no, maybe not the sole, but I felt like the sole male liberal in Texas and was looking to move to a different state that was focused on healthcare in a different way at the time. And so we had a range of states that we were looking for, and Colorado was one that was really focused on expanding Affordable Care, the Affordable Care Act, expanding Medicaid, and interested in interesting models to integrate technology. And so when I had done what I'd done at University of Texas Medical Branch and then moved to Galveston, they just basically said, just come here and do it bigger. And so the idea was let's try some things outside of the box, see if they're working. And so we've received a lot of support and a lot of grant funding and a lot of institutional buy-in for working on ECHO and telemedicine and e-consult in Colorado. So what I was going to tell you a little bit about is all the places that we're using it and how we're using it, and including pain management, and then take questions. So we do actually a lot of telemedicine and e-consult related things. And if you have questions about individual ones there, I'd be more than happy to talk about it. But I think we have 140 different use cases of telemedicine at the University of Colorado focused on interacting with various systems and different entities. And then related to ECHO, we're a really unique ECHO location in that I think you've probably heard about how people go to New Mexico, and for many who have been in a state who, as you've heard the description of hearing about ECHO and going, holy crap, it's the golden whatever police, and I'm going to go there and figure it out. Then they go, and there's really no funding model for it, and you go back, and there's no way to get paid for it, and you try to integrate it into a very non-integrated system, and it's hard to do. And so what we tried to do with ECHO was that and I think this is Dan's interest, was how we went about doing ECHO statewide, was that we spent about a year and a half going around Colorado trying to figure out who our right partners were, and then spent time rolling out ECHO in places that we thought it would fit best. And I don't know that I need to go into ECHO necessarily about the idea about what it's like, because I think you've heard that a few times. So in ECHO in Colorado, it started with the 5 professional schools at CU coming together to try to figure out how they might use it with their approaches and with their partnerships. And then we got initially a Colorado Health funding grant. There's not very much money, about $180,000, to spend a year going around doing really community-based participatory sort of research about, do you know ECHO? What is your relationship with the university campus? How has it been good and bad before, and how would you possibly use it if you did implement ECHO? And spent this time, and then came back and got another grant, a larger grant of about $4 million to start our effort on ECHO. And unlike most places that have done it where they come back with one disease state, we rolled out 22 different disease states and topics in our first year, which were basically what came back from our statewide effort to go around and find out what people wanted to use ECHO for. And this obviously was not possible without a great deal of philanthropic money. And then on top of that, my job, I work directly for the chancellor of the University of Colorado, and his interest is really figuring out how we could use it, how we might not use it, and figuring out where it works. And so they match up our money that we get from the Colorado Health Foundation to help figure out how we institutionally support this. So this is the state of Colorado, and it looks square. It's not really square though, because it's a little narrower at the top. But if you look at where we've had contacts or interaction or training, we've actually interacted in every state and every county in Colorado except for one or two. And each one of those dots or trainings that have been done in Colorado for various topics around that fit an institutional need or an entity's need. And so what I mean by an entity's need, rather than what is the usual relationship that a university campus might have with a community partner who says, we're here from the university and we're here to help, and we've got lots of knowledge, and wouldn't you like to know what we know? It's more so about what do you need ECHO for, and how ECHO might be used in your community or with your institution, and let's figure out how to pattern our approach to help you use ECHO or a range of ECHO or tele-related options to meet your objectives, as opposed to what the university wants to tell you about. So this, in effect, is kind of, our person who designs it likes to call it her Flux Capacitor. I'm not sure, anyway. Maybe it's not that exciting, but in effect, you have the ability to kind of look at this as a really, while it's from the university, it's a very university or a very community-driven model where our board of directors, when we started our ECHO, was not from the university. It was all people that are from the state that represent different organizations, different geographies, different interest groups, different ethnicities. So really so that we would focus on having a board of directors who drove what ECHO was doing going forward, as opposed to anyone ever being able to say it's from the university out, and you're telling us what you want to tell us about. And on top of that, we're at this point very diversely funded. With federal support, we have an AHRQ grant. With state support related to Medicaid and funding from Medicaid, a great deal of philanthropic support, a few different grants. And then the idea, too, is like, how do we get institutional integration so that we actually have entities paying us for doing ECHOs for them? And then you see this other piece, the collaborating organizations. What we do is we actually have taken some of our money and given it back to organizations, 6 different organizations around the state, that they define what ECHOs that they want to do to support their needs, and then we help them do the ECHOs with our infrastructure. So another lovely Flux Capacitor. And this really kind of gets to the array of partners that we work with related to working on ECHO. And so this far on the left are the different entities that we actually are doing ECHOs through to help them meet their objectives. So very broad thing, or very diverse set of things, from patient navigator training to being involved in the state innovations, the SIM model, working with the Kemp Center, we're the entity. So the Kemp Center is a child and abuse and neglect center that works around the state in every county, and we're the mechanism by which the Kemp Center does their efforts in the small communities around the state. And so a very broad array of topics. And then you'll see over there to the right, you see the actual network partners. Those are the different nonprofit entities that actually we give some money back to help them meet their clinical and/or education needs. The uniqueness of the ECHO, or the Colorado model as they've called it, is not a lot of the states that have done ECHOs have come in and done the planning process with a year or a year and a half of actually going around the state and figuring out how ECHO would fit for their state. And then you'll see it's also, we consider it much more of a multi-hub system, with the idea of interacting with these different partners to help them meet their objectives. Again, community-based governance, so it's not that town and gown sort of competition that always happens with university-led efforts, so that it's based upon the community's needs. And then again, focused on things that we have developed a thing called, it's a rubric, if you will, a scoring rubric that helps us define what are the topics that we're going to do relative to their importance. And then again, the ECHO limit kind of thing, the program center support, but trying to figure out how do we move beyond the idea of philanthropic support to much more of a braided funding model so that we get paid by a number of different entities, get it supported in other grants, have the institutional support buy-in, and continue it beyond what most people have happened is they lose their grants and then their echoes go away. So yesterday, Miriam came from the University of New Mexico ECHO Institute and spoke about the ECHO Act. So here we were in Colorado trying to figure out what we were doing with ECHO, how we were pushing ECHO out around the state and around the region. And lo and behold, Congress comes together and passes the one piece of legislation they passed that year unanimously. So every senator voted for it. There were 2 that abstained. And it passed the House of Representatives by every representative. So what piece of legislation does that sort of thing? Anybody have an answer? One that comes with no money. Okay, so there was no money attached. There was no money attached to the ECHO Act to pay for different things related to ECHO. But for me, because I had about $8 million in grants or thereabout, it was a hidden advantage because I had money to do all of the things that we wanted to do, and a new congressional sort of idea that says, you know, Congress says we like the idea. We like what's happening here. We want to see how it's used. We want to see if it could be used to lower the cost of health care. And we want it to sort of be taken out on the track and run to its nth degree to see where it should be used and where we should stop using it. And so in effect, that's what we've done. So we've gotten a lot of support from entities who now see the ECHO Act as something they're going, well, let's see if this works for this. And in the end, what the current administration cares about is cost savings. The idea about improving the health care or improving outcomes related to health care, okay, but tell me about how much it costs. So what we've been focused on is actually trying to demonstrate models that show no worse outcomes relatively, but do cost less money. And so any of the efforts that we're rolling, what we call our rational healthcare models out, are based upon topics that are priorities of the ECHO Act. So the ECHO Act specifically did speak to, and it's very broad relative to the types of things that you can put into each of those little categories, along with the standard things that often happen with ECHO, workforce development, helping community health workers practice at the top of their licensure, or helping clinical nurses and communities be an extender that have more capacity to do more things in rural communities, all those kind of things related to workforce. And then, of course, public health related topics, which are of importance there too. And then to really focus on how do we do things more effectively and more cost efficiently in rural and underserved areas. So the ECHO Act goes on for 2 years, in effect, with a third year for writing reports, what's happening with it. In effect, ECHO, the folks at Health and Human Services have already written this report, and they're trying to actually push it to Congress to get feedback about what Congress wants to do back in the various states. And so this next one here is we're talking about, I know Dan had an interest in this, it's the Medicaid for our state. If we can figure out how we get it integrated into Medicaid and have Medicaid using it to be more effective and cost efficient in their health care use, it's a great benefit. So this is not a flux capacitor, but it's kind of a graph, and I apologize, there's some spelling issues here that we're actually trying to to shorten up the title. But this, in effect, is kind of a graphic representation of the flux capacitor, if you will, that get at all the different topics that are going on for ECHO Colorado right now, and how they meet the various priorities that are those channels up there related to national priorities, and then the idea about which ones do we do and which ones do we prioritize. So if you come across one that has more than 2 dots or 3 dots, those are efforts that we're working on because they're a high national priority. They meet key performance indicators of Medicaid. They're an FQHC topic, or they're study opportunities that we've gotten money for. So lots of diversity there, but topics I think all of you could see an interest in. So another lovely flux capacitor. And this one gets at the end of the day, we don't know if echo works, frankly. So the idea about where it works and whether or not it works, it's not meant to be every place and everything. It's not meant to be something that is sort of a new cure. What it's meant to do is, I think, and what the ECHO Act kind of forces us to do, is to figure out where it works and where we can get paid for it and where there's a benefit to it. So the idea that it works everywhere, I disagree with that completely. And I actually disagree with the idea, I agree with the folks from the Weizmann Institute yesterday with their idea that ECHO by itself, for most things, is not of great benefit. It needs to be paired with both telemedicine and e-consult and other approaches to trying to focus on how do you put those things together to make sure that you're benefiting your health system. So this, in effect, is our flux capacitor for braided funding. And so if you look around the topic titles, so we're looking at some point to be away from pure philanthropic support, but how we keep it going would be partnering with the state and having it aligned with various state initiatives where they say, this helps us do blank, and thus we're going to pay you for doing that. Federal support, we will maintain some amount of grant funding and continue to be written into other people's grants as they say, we really want to do a neurodegenerative palliative care PCORI grant, and it's going to be in 5 states, and we're going to be the core model here in Colorado, but we're going to be connected to 5 different entities, and we have the expertise. Natural opportunity for ECHO and to build those collaborations. But again, trying to figure out where it works and where it doesn't work and how we get continued funding for that. The other deal would be university integration. There's all sorts of things that happen at the hospitals for our different entities, the Children's Hospital and the University Hospital, that they want to do and they would like to do more efficiently. And a great example in capitated models would be Medicare Advantage. So if you are on the hook for a range of expenses for a set population that you are the payor and the provider of benefit, ECHO and the use of ECHO for managing certain chronic conditions is actually a pretty good model. So the idea about how you put it into that sort of effort to change cost or lower costs in a capitated system makes a lot of sense. And then at the other end, what we've done is we've developed a very robust data management system and recruitment system, and it's just a sort of ecosystem, if you will, or echo meta system for helping set up the echoes and manage the echoes and prepare for the echoes and push out the videos for the echoes, all of that stuff, that now a number of states are also wanting to buy that from us to help them manage their echoes. So again, trying to get at all the different things so you have this braided funding to maintain your effort as opposed to going with one effort or grant, as most people do, and losing the grant and then having to go away. So this has been called the Colorado model, if you will. And the idea that we have here is the use of these different sort of mechanisms together as opposed to standalone to provide a flexible use of technology in a healthcare setting. So I love to use type 1 diabetes because it's an effort or a disease state where you have a global mechanism that demonstrates general well-being, the A1C. And if you go to the ADA standards for managing type 1 diabetes, it will say you should see a endocrinologist or board-certified endocrinologist 4 times a year as much as you can. Now, if you're poor or you live in rural parts of the state or away from the main medical campus, that's largely not going to happen. And so what happens is you see those people who have 4 visits, they don't have 4 visits, they have 1.3 visits or 2.3 visits, and then with sloping A1Cs and poorer management of their disease. And so if you took this model and walk with me through it, is that so the idea would be if you said to the providers and the system out there that what we'd like you to propose is not have your patients come to the campus 4 times a year, but say they come 1 or 2 times a year. And that one time a year that they come to campus, you'd you check their fluids, you put new windshield wiper in, you put new air in their tire, all the basic kind of stuff, baseline kind of thing going forward. And then the idea for the next visit that they have, the next scheduled visit, you would push it into a telemedicine visit where they go into their primary care provider closer to their home or in their school, and you bring that specialist into that care setting via telemedicine, who sees them, sees how they're being managed. Then that primary care guy or gal who's out there who's seeing more diabetics, more asthmatics, more depressed folks, more people with drug-related things, is thinking, I need more training in all of these things. So he or she has the ability to go into the full range of different echo topics that are going on or series that are going on and drop their case into an echo, get feedback about how to manage that, and then the next time the patient comes, you have more ability to manage that condition more orderly, I guess, if you will, or getting more experience of managing more of those conditions. The idea about having the e-consult there too is echo is de-identified. So if you're one of the providers out there and there's 10 or 12 that are sharing cases, they're all, it's a 12-year-old that has type 1 diabetes that lives in this section of the state and some basic biological information, but ideally you shouldn't know who that patient is. But if you're the provider and you're off on your formulary or your treatment module is off, the e-consult or the people on the echo panel, who for endocrinology might be an endocrinologist, a nurse, a pharmacist, and maybe a clinical social worker, might say to you, well, you're kind of off there. So they would push that into the idea, we need to talk specifically about this patient and move it into the e-consult world so that you could speak specifically about that patient and their specific condition. So the idea, again, is more of a sort of waxing and waning model of care to focus on that. We have this happening, and this is a problem with why I couldn't load it because the slide is too big. But we've made a video of this, and I'm going to try to play that in a minute, related to how this all works in reality. So for these particular kind of conditions, what we've done is that we have these rational approach pilots in these different areas, and any number of other ones. But the idea of these are they're specific models that I think will resonate with you. So for the Pediatric Asthma Management School-Based Clinic, Children's Hospital Colorado has a relationship with Denver Health, which is a safety clinic or a catchment clinic in Denver. And every year, Denver Health comes to Children's Hospital and says, okay, we've got this much money, and what will you give us for that? And Children's, in all of their wisdom, says, we'll give you our youngest, least experienced pulmonologist, who's going to drive out to that school that's on the other side of Denver, and he's going to be there for 4 hours a week. And so what ends up happening after he drives across Denver, he's there for 2.5 hours a week, and since it's 4 hours instead of 4 appointments, and they know that's all they're getting, they shove 15 people into that clinical spot. And so none of the people get really good, adequate care. And so you sit there and you go, so how does ECHO fit there? So ECHO wasn't a natural fit. But what we did was we decided we're going to change the model where he has a good relationship with these clinics and he has a regular set of patients. So we're going to double up his FTE, and he's going to go to 3 clinical spaces via telemedicine instead of going and driving in person. So he doubles up his FTE. Then on the back side of that, what we add into that is an e-consult mechanism so that each of the school-based nurses can use the e-consult to park synchronous and asynchronous questions about managing their patients so that he and a panel at the university give feedback about how to manage more of that. And then on the back side of that, you have an ECHO panel, so each of those school nurses and those teams in each of those schools share cases with each other and talk about how to manage more things on their own. Again, the idea is trying to push more resources into that community so they're practicing more with their own capacities and growing their capacities to do more. And then evaluate the poo out of it. So ECHO has not been very well or very thoroughly evaluated, but this evaluation has school-based attendance, emergency room for asthma, the regular pulmonary outputs, and all of those things that we're going to look at relative, not just changing knowledge of how they're dealing with asthma, but also changing the patient outcomes as well. I won't go in much detail with all of these, but the core effort, Children's University Hospital is pushing out an internal e-consult mechanism. And I was talking to someone a second ago about really a lot of clinicians, this is a new world for them to figure out what's an appropriate consult in e-consult, what's an appropriate telemedicine case, and what's an appropriate in-person visit. And so the core effort, in effect, is trying to retrain the clinicians about what's an appropriate use of these different mechanisms. So if they're trying to push a very complicated case into an e-consult that they've had struggles with this one forever, that's probably not an appropriate first e-consult kind of thing, or it's not an appropriate telemedicine for that matter, but really trying to refocus how they use e-consult appropriately, how they use telemedicine, and how this is a really complicated case, we need more time with this one in person before we move it into these other mechanisms. So it's in effect a meta-echo, if you will, helping retrain the clinical approaches for dealing with these different things. And then what will come out of this, as we hope, is that as we sort of can, if you will, hotspot or geocode relative to where we're finding spots of more asthma or more whatever, we can push more clinical expertise or more clinical efforts into those areas and push more education out to various practitioners through ECHO. Why I mentioned adult rheumatology is one of the struggles I've had pushing ECHO into these different places in telemedicine and in these different locations is those people called chief financial officers. Because they'll say, okay, so how much money is it going to cost me to save this much money? Questions like that kind of ridiculousness, right? Okay, so rheumatology was one where we had done a really good study with a cost-benefit analysis for psychiatry, where we demonstrated an impact that it took 112 patients to pay for integrating the system into behavioral health, into emergency room telepsychiatry, which was a fourth of the patients for the year, for paying for all the technology, all the pro rata employment costs, all of that to integrate into a specialty. So they have a lovely kind of crosswalk, if you will, to take to all the other specialties at this point and say, this is the kind of thing we're going to come do with you next. This may not be the exact model, but let's figure out how we make your pathways more efficient. So we were thinking about efficient pathways to care, and my medical director for ECHO is a rheumatologist, and I was like, so how many of your patients do you absolutely need to see in person? And he said, let's say 35%. And so the idea was to kind of go back in and look at all the coding and all of the different sort of procedures and all the different patients for his patient panel for a year, and to figure out the ones that he thought he needed to see in person, the ones he could push out to e-consult and telemedicine, and then to look at whether or not we actually did do what the chief financial officers were worried about, which was reduce revenue by pushing people into telemedicine and e-consult. And our outcomes were, we increased revenue by 6 times. And so the idea was, so you move all these people that were non-procedural out into telemedicine and e-consult in more of these virtual models, and then he has a 9 or 10 month waiting period, and it pushed all the people that needed procedures earlier into the queue and got all of those people into getting their appointments quicker. So in effect, in a year, we had a 6-to-1 revenue generation for this, and it won't work for all of those, but I can guarantee it may not be 6.6 times, but for rheumatology, GI, asthma, some of those things, this is a model that would work quite well for those conditions that will actually both change the pathways and increase revenue. The Pediatric Polypharmacy Management, this one has a really robust study that's a randomized control trial, but in effect you have primary care doctors who are out remotely. And this is one of those things that it was a study that made sense, and then for Medicaid, one of their key performance indicators was the management of polypharmacy in foster children. Because in effect, you have folks who are out there who are primary care doctors who are seeing the mom, the dad, they see all the other kids in the family, and then they see this foster child who's on, in Colorado, the average is 3 times as many psychotropic drugs as the other children in the state. And so it's bad for their health, but for Medicaid, their main concern is it costs a whole hell of a lot of money. So could we work with the state to help them figure out how to be more healthy in prescribing, but also reduce their cost in managing these children? So in effect, this is what we're using ECHO and eConsult with these primary care providers, and looking at, through drug utilization data for the state, their 6-month prescribing and referral patterns for the 6 months prior to the training and the effort and their e-consults, and then looking at their 6-month post-prescribing and behavior after that, and comparing those outcomes relative to whether or not we save the state money. We're in month 4 of the after training, waiting for that 6 month to kick in so that we can go in and look, and everyone's kind of going, oh my gosh. We'll see what happens with that, but I think it makes a whole lot of sense, frankly. The other topic is for veterans. I don't know if you know about choice clinics, but veterans who live in rural locations around the state, if they can't get to an urban setting, they go to a primary care clinic, same as the ones that are managing the foster children sometime, and they can get any of the care that's supposed to happen through the Veterans Administration at this choice clinic. But then they're stuck trying to deal with these veterans who may have pain or polypharmacy issues, or substance abuse issues, and all the sort of trauma related to being a veteran, et cetera. And we're doing another very similar effort with the Veterans Administration focused on the polypharmacy management for veterans. So in the end, these are our themes for what we do and what we're going forward with and how we hope to maintain this. It can't stand alone, and it's got to engage. So I have a bunch of lovely public health-minded MPH students and individuals that work for me, and they want to do the right thing. But we also oftentimes have got to be very functional in our approach to say, how do we do what we do and convince people that what they do could be helped and they could get better outcomes by using what we do. And that's a very long way to winded approach, but in effect, using us to help their jobs easier or their outcomes better. And we brand it and operate it as a system, and so it's sort of, we partner with these entities, we brand their entities, we let them sort of use that, and then rather than someone, at some point, someone called me from some state and said, I called New Mexico, and they called you the Rent-A-Echo. And I thought, okay, so what is Rent-A-Echo? So tell me what Rent-A-Echo means. So they said, well, we've got an idea, we've got a training we want to do, and they said, if we came to you and it was a good idea that fit your metrics, that you would use your resources and your system and your staff to build the curricula, to help manage it, to push it out, and help us evaluate it. And I said, that's what we do, so I guess we're Rent-A-Echo. So I don't like the Rent-A-Echo moniker, but the idea would be that we're sort of known for, we help you meet your objectives, and so it's that. And the next one is sort of scalable. So something that works kind of in a microcosm or in a special circumstance or whatever is really, in my opinion, not worth doing. It's got to be something that actually works and is scalable. It's got to work small, it's got to work big. And if it doesn't work big, in the end, people are not, the institutions and the entities and the Health and Human Services and Medicaid are not going to pay us to do it. It's got to be scalable. We focus on smart growth. That gets back to the rubric, the idea about it has to score well in our mechanism to demonstrate it's going to be something that we're going to do and move forward with. And I've already mentioned this, but it's got to have outcomes that matter to our partners. It's got to be something that they think this is going to help us do what we want to do better, and it makes sense to us. And I guess the next one is sort of the same. Societal high-impact trainings, and it kind of fits on that graph I showed earlier, where it fits a key performance indicator of a partner. It's on the ECHO Act. It has a sort of combination of things that fit whether or not we're going to do it or not. And I guess that's repetitive, delivering value. And then at the end of the day, opioids are the topic. And so the idea is like, so we could do all of these different things, and then kind of, if you will, stand on the sidelines and not help our state deal with the opioid epidemic, and it would be a problem. So we are also involved. We have a randomized controlled trial for medication-assisted treatment for opioid as well. And I'm not sure how many randomized controlled trials, but if you saw that map yesterday, we're that black square funded by the AHRQ to focus on how we train primary care providers with MAT.
Many inefficiencies in the healthcare system. For a patient needing healthcare,
Let me see if I can get my volume higher.
there are many inefficiencies in the healthcare system. For a patient needing healthcare, these inefficiencies can create unnecessary treatment barriers for patients, diminishing their experience and negatively affecting their health outcomes. At ECHO, we see this as an opportunity for improvement. We connect health professionals from different communities with a variety of knowledge and breadth of experience and allow them to share best practices and resources to improve the quality and efficiency of healthcare. ECHO, one part of a bigger practice paradigm. Together, we want to make the inefficient efficient. With coordinated care, a decreased need for in-person appointments, and an improvement in overall healthcare value. By empowering the integration of the practice paradigm into the patient-centered medical home and medical neighborhood, we can optimize talent, techniques, and technology. Shared knowledge from specialists and experts creates opportunities for other providers and staff to practice at the top of their ability, increase capacity, and efficiently manage complex care. With your help, we can institute a new, efficient practice paradigm that optimizes patient experience and outcomes, lowers the per capita cost of healthcare, and improves the work life of our tireless healthcare providers. Knowledge held by one has the power to change lives. Knowledge shared by many has the power to change the world. A better life for patients and providers starts here. Let's ECHO.
So I'd been going around. I have markers in my pocket all the time, and I'd been going around to various CFOs or CMOs' offices and drawing stuff on boards, messing up suits. And at some point, our staff said, "Let's do something that's cleaner and neater than your writing, because no one can read it." And and now they like to joke that this was everything that was in Fred's head in a minute and a half. So, and which is probably true. So anyway, so in effect, what we do now at this point is we kind of go and we give a spiel or talk about with a partner, and they generally get this. So a CMO or someone at an institution that's trying to think about how they're integrating these different things, it makes sense to them. And then we figure out what is the approach that you're trying to address, and this has helped a great deal. So. That's it. I'm sorry I didn't have as many exciting stories, and I'm kind of a nervous speaker, but I appreciate your time. And if you have questions about what we're doing or what we could do to help you, I'd be more than happy to take questions. Thank you. Yes, ma'am.
That was fantastic. I love your rational healthcare slide.
Yeah.
But I have a very specific question for you. Could you talk a little bit about how you're using ECHO with child abuse, prevention, neglect? I just didn't ask you.
Yeah. So the state of Colorado gave the Kemp Center the contract for training abuse and neglect teams, or the child protection team for each of the counties. And what happens is, like, so if you move away from the I-25 corridor, which is where everyone lives in Colorado, out into, pardon me, if you move closer to where the airport is, frankly, in Denver, it looks like Kansas. And if you go to the far west, it's largely rural as well. So the child abuse team, or the child protection team, might very well be a nurse and a police officer or an emergency room doctor. And so the idea about having the full array of different people on a team that you could use to help you manage cases and manage scenarios that help you decide what is the right thing to do is how they're using ECHO. So we basically, they're one of our hubs, and we've trained an integration manager, which is one of our kind of case managers people that sit over in Kemp Center. So they don't do any other echoes except the Kemp Center echoes. And so they're doing them all the time relative to helping those different counties manage the child abuse and neglect cases that are presented. And then they, of course, if you're in the rural space, we give CME, CNE, C whatever for all of these things as well. In Colorado, it's less effective because Colorado doctors don't have to do CME. You don't have to get CME in Colorado. You have to do MOC, which you could get through CME kind of related, but you don't have to do CME. So we've paid for these, thousands and thousands of dollars of CME credits, and generally people don't come and get them. But nurses do. Nurses go after them like hotcakes. So did that answer your question? Yeah. Okay, and I'll answer more if you want. Anything else? Yes, ma'am.
Good morning. Great presentation. Thank you. I have a question about how do behavioral health therapists fit into the ECHO model? I've been able to see other disciplines, but how do we fit into this?
Yeah. So a good model is the behavioral health integration models for primary care doctors. So if you have a bunch of primary care docs that are out trying to figure out how to do integrated behavioral health or practice transformation, who might sit on the panel on our training side would be a psychologist and a psychiatrist that are helping primary care doctors manage conditions that are coming in through their clinic site. Or you might have a group of psychologists that are coming together from different entities that get help from a panel that give them more or give them sort of you get 15 or 20 minutes didactic on a topic that help you manage with some sort of scenario, and then you get to share your cases with others listening to them, and each of those providers listens to each other and then gets feedback by someone who has more experience or a different approach about it. So any number of sides, you could be on the side where you're being trained, or you could be the person who's on the panel giving training. Yeah. So tell me what you're, so the really kind of great thing would be to sit and say, what are you trying to do? And for you to just kind of sit and think about what would be the right approach about it. Because I mean, it doesn't really have to fit one specific drawing of it. It's the idea of like how.
That's what I was trying to determine. So we're going to follow up with the information we received on Wednesday.
Okay.
And just speak more specifically about the population we serve and if it could be something that we move forward with.
Okay, great. Yes, ma'am.
A lot of times with the behavioral health model, it's successfully done at the psychiatric level, but where it sort of stops is, and most patients that are getting behavioral health treatment, whether it's mental health or SUD treatment, very rarely see a psychiatrist.
Yeah.
Where it doesn't seem to have penetrated is the other levels of care within the continuum of care, the clinic, substance abuse clinical staff, mental health clinical staff, social workers, LPCs, things like that. That's where it seems to kind of run into the regulatory systems and the laws and the state rules that are siloed out of the primary care system.
You are correct. Yes.
And it seems to hit a barrier there.
You're correct. So I apologize. I've been told that I have to go away now. So, but if you have a question, I'd be happy to come and address your question specifically. But thank you again.
Let's hear it for Fred.